All right, hey everybody. I wanted to do a quick video just to review some of the concepts we went over in week one for the lecture series for all the PowerPoints. So I'm going to keep these quick, maybe like 15 minutes apiece, just to run down the basics, some of the things that you may see on your quiz, some of the highlights, just for each section of that. So we'll kick it off here, just kind of quick and easy with the first PowerPoint. This is one that I just wanted to look over and give you some asterisks, some highlighted points, reviews, just to think about in terms of studying your preps for moving on into the quiz coming up next week. So here's the Intro to Therapeutic Interventions 1 PowerPoint. Definitely go ahead and review this if you get a chance. We looked at the syllabus. That's great. There's great. Good. Basics of intervention, right? The coordination, communication, documentation, patient-client related instruction, direct intervention. So that's where the PTA lives. Direct interventions is pretty much where we as PTAs live in terms of assembling the protocol that's passed down to us from the PT and then implementing that protocol in a sensical way that shows progression and maximizes the outcome for the patient. So for this class, really, we're going to be more involved with the idea of physical agents for rehab. What we primarily want to look at is our uses for the application of physical agents primarily to accomplish these goals. So what are the physical agents in general? Well, they're energy materials that we use and apply to patients to assist in the rehab process that supplement some of the other things that we'll learn, like exercise programming, stretching, etc. Physical agents include mechanisms that are going to derive their benefit from heat, cold, water, pressure, electromagnetic radiation, or electrical current. So these are all things that we're going to learn throughout the course of the program, the course of this curriculum for this class. Application of physical agents, what are we trying to do when we're putting these? We're using these mechanisms to get a certain kind of result. What is that result? Well, it just depends on what we use and how we use it. So our main aims typically are going to end up being, like we discussed in class, reduction of tissue inflammation, acceleration of tissue healing, relief of pain, altering of the collagen structures of some kind, and modification of muscular tone. All right. So within the healing process, this is going to be a part that I want you guys to pay attention to. Obviously, all of our interventions are going to be, to some degree, framed out or structured in a way that's going to respond to where that patient is during the healing process. So we're going to talk about inflammation, the 4 phases of healing, and figure out what modalities we can use along that pathway of healing in order to best affect the patient. So after an injury, we know our patients come into us with some kind of underlying soft tissue structure damage, typically. The body's going to undergo a natural healing process as a result of that damage. And those healing processes can be broken down and better understood by subcategorizing those phases based on a certain timeline. So timeline for healing is going to be different for everyone, like we discussed. So there are factors that are going to contribute to the timeline for healing. These would include how bad the injury was or the extent, how old the person is, and overall health status. Are they dealing with any comorbidities, as an example? Okay, so here are the healing process phases. The first one is the bleeding phase, then the inflammation phase, what we call proliferation or the fibroblastic phase, and finally the remodeling or maturation phase. So each one of these is going to have distinct characteristics important for your quiz and moving forward in your greater licensure exam, that you understand these phases very well. Bleeding phase we're familiar with. It's the short phase right after you get an injury. It lasts, again, these are time frames. I don't want you guys to get pigeonholed into thinking like, oh, well, it's been 24 hours and they have to absolutely be out of this phase or that phase or whatever. Everyone is a bit different, so you can't really hold these maxims to be true for every single patient. But the bleeding phase is initially the first phase you'll go through, lasts about those first 6 to 8 hours, sometimes up to 24 hours if the injury is really bad, like a crush injury. Time of bleeding depends on the extent of the soft tissue injury that's present and how we manage it after that. So obviously, the more vascular tissues or the more vascular structures that you injure, the more bleeding that's going to occur. I think that's a fairly sensical ratio. The inflammatory phase is the next phase we'll encounter across the healing phase or process of healing phases. Inflammation or the inflammatory phase is going to have 3 big purposes. So the first one is to form a fibrin lattice that's going to limit the blood loss. We want to stop blood loss by forming this fibrin lattice. It's going to provide initial integrity or strength to the wound. Then we want to get the damaged tissue out of there and start to recruit those endothelial cells and fibroblasts to initiate or move into the more initiating phases of healing, where we're going to repair and then also rebuild what has been damaged and for it to be replaced. Inflammatory phase. So you're going to start fairly quickly here, 6 to 8 hours after the injury. And again, usually reaches its maximum reaction between 1 to 3 days. And you can feel this, right? You twist your ankle really bad. It starts, you have internal bleeding during the bleeding phase. It gets nice and purple, then starts to swell, gets really big, looks like a grapefruit. And you kind of peak out in that inflammation phase about 1 to 3 days. It's really swollen, right? This is achieved by, again, local vasoconstriction in the area, retraction of the injured blood vessels, the depositing of fibrin in that area, and then blood clotting. So the blood supply to this area is going to increase at that time. That's what causes the edema and the redness, and that's a useful tool, again, to bring some of the, what we're going to find, healing cellular material, things of that nature to the area, immune material to that area. So this is almost like a transportation phase, right? We're trying to set the stage for what's to come next. These are massive, right? So we have to know, and you definitely should know, the cardinal signs of inflammation, without a doubt. If you're moving through the 5 major ones that we're going to consider are going to be always pain, heat, redness, swelling, or loss of function. So erythema is going to be another word for redness, swelling, inflammation. And then because of a conglomerate of these things, a loss of function as well as a result. Okay. Here's the inflammatory phase. So we get a cellular response at the level. We have a number of different smaller cellular materials, tissue materials being moved to the area and also removed from the area. So things like leukocytes, phagocytic cells, exudate or lymphatic fluid, blood, and the damaged cells that were initially impacted will all sort of be in the general area during the inflammatory phase. We also have platelets, which are going to adhere to vessel walls when they're exposed to collagen fibers from the tissue injury. And they form these plugs along with the leukocytes. So here's your step-by-step. Not super concerned that you know the anatomy here. You can just see here's damage. There's vasoconstriction happening with vascular spasm. You get the platelet plug formation between the collagen fibers reaching the vessel walls, and then you start to have these leukocytes form along with the platelets together to give you this kind of combination of a plug, right? And then the plug, in essence, will introduce fibrin to the area, which will give you a mesh that's going to help trap the blood cells and the platelets and form the actual clot. So again, not super worried about the anatomy or the physiology here. When you have those damaged cells, they'll release something called thromboplastin. So here's a long line of chemical reactions, chain reactions. Don't worry about that. But once you release the thromboplastin, there will be a few things that come after that. And finally, you'll have that fibrin clot formation that we see right here. So the injured area becomes walled off, which is the intention of this whole process. And we want to create a barrier because this will allow phagocytic activity at the site of the injury. So we want to wall it off, not only to form the clot to stop the bleeding process, but also to almost, for lack of a better word, entrap any foreign entities or bodies that may have entered the body or any of its systems as a result of being exposed to the external environment. Here's your chronic inflammation. Again, one thing to remember, this is different from chronic inflammation because chronic inflammation is typically due to low concentration of chemical mediators. So the tissue never gets back to a normal state. You end up having, there's this typically comorbidities involved in creating chronic inflammation that contribute to the low concentrations of the chemical mediators. So here are some of the things that may be going on behind the scenes that will lend themselves to chronic inflammation. That's probably all I need you guys to know in terms of chronic inflammation. I'm trying to keep these fairly short and to the point here. So Proliferation, we're talking 3 to 5 days, and overlaps with the inflammatory phase. So this is where we say they have sort of a Venn diagram. These aren't just, it's not like the inflammatory phase ends and the proliferation phase takes place. They overlap, right? So there are multiple processes occurring at the same time. You have the formulation of this granulation tissue that has all these different things inside of it. Again, not super worried about the physiology or the anatomy of what's going on per se. You guys have learned this before in Anatomy 1 and 2. Chronic inflammation, again, can lead to prolonged fibroblastic activity. So inflammation that's not shut off, right? There isn't that chemical moderator that says, okay, we've got enough of the inflammation, we don't need any more. You have these continuing processes, and because of that, you can end up with proliferation of excessive scarring. So there's your fibroblastic. Here's fibroblasts. Again, this is going back to A&P. Maturation, or the remodeling phase. This is the longer term process. So as you move out of proliferation, the remodeling phase is a long-term process, and this can take anywhere from, you'll get 3 weeks to form a firm, sort of strong, contracted, non-vascularized scar. So that's your scar tissue being laid down. But the maturation phase in general is not necessarily about just laying down the scar tissue. That's more proliferation. We want to place stress and strain on the scar tissue to help it to realign and give it a parallel fiber so that it has more mobility. So this is one that may take a long time. It could, in fact, take up to several years for full healing to occur. So those are the basic phases here of the healing process. These are all factors that can influence the healing process. You should know these, and some of these are intuitive. Type, size, and location of the injury, right? A paper cut's not going to be the same as a massive trauma from a car accident. Infection, potentially. This is always something very, very important that we have to keep our eye on. The available blood supply to where the area might be. So if you're talking about a cartilaginous structure versus a muscular structure, there's going to be a difference in the blood supply to those tissues, and it's going to result in a change in the healing process timeline. The amount of edema still remaining, and then movement and excessive pressure on that area. So if I have a paper cut on my finger, I keep opening the finger, it's going to elongate the healing process. And here's this in detail. This is one thing to know. Infection is always going to be your most problematic local factor. This is the one we're paying attention to most. Infection gets all the bells ringing. This is what we really, really want to hone in on in terms of identification and monitoring of our patient, particularly following an extensive open wound. You can see some statistics here. 50% of wound complications, that should be wound complications, are due to infection. Poor vascular supply, again, we know edema, we've gone over. The systemic factors are things that we're going to learn through the med history that you should always pay attention to. These are just know the factors themselves and have a working understanding of why each factor contributes to or an alteration within the healing process. Medication, things like this, nutrition, right? And then modalities. So how are we going to affect the healing process? Well, we're going to use our modalities, our physical agents, to do the job. So in an acute injury, the primary goals for our acute injury are reduction of pain and reduction of edema or swelling. So we're going to use different modalities along the injury management timeline to allow us to affect these processes throughout the healing timeline. So cryotherapy, compression, combined compression with cryotherapy like a game ready, ultrasound, all these things you'll learn later on. Here's the inflammatory phase, right? So we're looking at these the timeline for going through this phase and things that we may start to use. Again, the goals are very similar at the very beginning because even in the inflammatory phase, we're still sort of acute, or what could be considered also the maximum protection phase. So decrease pain, decrease edema. How are we going to do it? Cryotherapy, compression. We might start to include electrical stimulation once we've gotten a little bit farther out, and manual lymphatic drainage. Once we move into the fibroblastic or the repair phase, proliferation, typically 4 days post-injury, but again, this varies. We're sort of shifting our focus. We're still addressing pain, but we're trying to move into addressing types of dysfunction now. Once we get out of that acute inflammatory phase, that will open us up to some new modalities we can use, things like heating therapies and stronger electrical stimulation modalities for both sensory and motor purposes. So that opens the doors to new things. And then once we get into the maturation phase, we know this can take a long time, but we sort of shift our focus from management of pain and edema towards restoration of function. So some of our restoration of function and assistive remodeling of the collagen fibers or the scar tissue that might be remaining. So by the time you get to this phase, not that we haven't phased out all available modalities, but we're trying to limit their use in terms of their capacity for specifically pain control and edema. We're definitely going to reuse them if we have a sort of a jump, right? Or a flare up in their pain and edema based on what we're doing programmatically. So we can go back to a hot pack, we can go back to a cold pack, whatever. But we don't usually want to be using these all the time. We want to shift focus onto functional return at this phase. So go to your book or just look at this PowerPoint. I recommend printing this out. This is a really nice synthesis of all the things that we've talked about in terms of the appropriate timeframes for each phase, things that we're going to be concerned about or how it looks as far as clinically, what modalities we might use, and why we can rationalize using those modalities. So therapeutic modalities we'll learn about. You guys don't know these yet, but we'll talk about electrical modalities, iontophoresis, biofeedback, diathermy, cryotherapy, thermotherapy, ultrasound, laser, and massage, all important parts of what we're going to be doing. And that's just the basic review for Intro to Therapeutic Intervention. So I've highlighted a few concepts to really think about, specifically going back to your stages of healing, understanding the factors that affect the healing process, knowing specifically not only from a timeline perspective, but what is actually happening during these phases, not specific anatomical or physiological events. I'm not going to hold you to that, but you should know generally what the priorities are, the body's priorities are during each specific phase of healing. And 100% cardinal signs of inflammation, know those backwards, forward, sideways. And I think for the most part, that is pretty much it. So there's your first one for therapeutic interventions. One, just a review video. I'm going to post a couple for the remaining PowerPoints that we talked about in terms of pain and for your soft tissue mobilization introduction as well, just to give you some highlights for your studies and to solidify your knowledge moving forward.